Hoffman. He's a joint replacement
Recording
guy.
in progress.
The top left there is Peter Stevens, one of our pediatric guys who really taught me the PAO early on. Jeff Mast is down below on the left. And you probably know Jeff Mast and Reinhold Gons in the upper right created in 1984, they did the first PAO operation. I met Reinhold through the folks on the left, and then I became very good friends with his kind of chief disciples. That's Michael Loinig, Martin Beck, Klaus Siebenrock on the right, and started kind of a collaboration with them between Utah and Switzerland. And I try and pretty much go every year to kind of get a little tune-up on the state of hip preservation with these guys. And my education has kind of continued along with contacts with American or North American surgeons. Some of these names you'll recognize. I won't go through all of them, but these are kind of the giants in hip preservation work in North America. And that picture there in the middle is from the 50th anniversary of the Hip Society when we carved out just the hip preservation guys there in the middle. So in my mind, as I look through this kind of journey of learning and doing and then researching the PAO, to me, it's a little bit like life. These are the things that I think are important to me in life. And interestingly, I think they're important when you look at the progression of PAO surgery over the last 20 or 30 years. So honor your mentors, be humble, enjoy inquiries, celebrate the victories. The value of mastery, we're going to talk a little bit about that and then pay it forward. So hip dysplasia, I think most of you know, it's defined by deficient acetabular coverage for the most part. If you really want to simplify it, I think most of you can appreciate that socket there on the right side is upwardly sloping. The sourcil is upwardly sloping. It's a deficient volumetric socket. And that's what most forms of dysplasia have. And certainly we call this classic dysplasia. There are other forms. We now know it's a three-dimensional problem. And we also know that dysplasia presents usually as hip instability. And now we have this whole other camp of structural hip disease called hip impingement. It's really the other side of the spectrum of structural hip disease. So that's an over-constrained hip, usually reduced range of motion, whereas the other side on the left has hip instability and increased range of motion. This is the important concept, is that you can get a labral tear in the middle there with any of these conditions. And for many years, unfortunately, I think a lot of our surgery was kind of focused on treating a labral tear as the pain generator. And what we find really is that if you focus on treatment of the labrum, most of the time outcomes will not be great. And so you really have to focus your treatment on the underlying morphology problem, which with hip instability is usually a PAO. And with hip impingement, nowadays we treat that with usually arthroscopic surgery and some type of bone removal, either on the femoral side or on the acetabular side. So the indications for periacetabular osteotomy today, I think a little bit controversial. It keeps, I would say in North America, it keeps going down, primarily because of the success of total hip replacement. So with advanced polyethylenes, with highly cross-linked polyethylenes, you know, we're seeing our 40 and 50-year-old patients do incredibly well. So the upper age limit for PAO is probably closer now to sub 40, maybe around 35 or so. You can see the typical symptoms. We need somebody who's going to understand that this is not a hip replacement. This is going to take a little bit longer in terms of rehabilitation. The radiographic findings we've seen, and I'm going to show you some cases that illustrate this: upwardly sloping sourcil, deficient lateral center edge angle, less than 20 or 25 degrees. We need to usually have a congruent hip, although not always. Retroversion is a whole nother animal. And then importantly, we need fairly little osteoarthritis, so tonus grade 2 or less. Otherwise, the outcomes tend not to be as consistent. So this is the results. This is the mean 20-year follow-up of the original 58 patients done in Bern, Switzerland by Gons and Mast. And what we see at 20 years is 60% survival. Now I think this is a very low bar because this was the first 60 patients. They were still working out the surgical technique. Nevertheless, 60% survived at 20 years, and it's kind of given others encouragement to continue to do this over a long-term basis. It's really now, the PAO is really the mainstay of treatment across most of the world, except probably Japan, where a slightly different type of rotational osteotomy is done, but the same concept exists. So this is a 21-year-old female. This is the kind of case that we see today, 5 hip scopes. So not uncommon that patients have had a lot of hip scopes before they see us, and we kind of figure out, you know what, they probably have hip instability, really, not hip impingement. She's pretty debilitated. Her hip score is 62. If you look closely on the AP pelvis, you can see much of her femoral head is uncovered, especially from a wall standpoint. So posterior wall here is extremely small and diminutive. And this is an example of a retroverted acetabulum. You can see this better on 3D imaging. So we often have low-dose CT scans on these patients to quantify the deformity. We do MRs to kind of look at the state of the chondrolabral surface. You can see that femoral head's been over-resected from a cam standpoint. We have a big capsule anteriorly. All these things contribute to hip instability. And so here she goes and has bilateral stage PAOs on the left 1 year, or on the right 1 year, and on the left 6 weeks in this x-ray. And this is the kind of result that we get. And, you know, a lot of people are scared of this operation because of the complexity, the morbidity, but this is the type of result, when it's done well in the right patient with the right indications, this is the kind of result that we'll get. And this, you know, I think a number of studies now show this will be a lasting result for 10 to 20 years in most patients. So I say celebrate the victories because we've, from a literature standpoint now, you know, we did a lot of this by inference in terms of whether we were altering the natural history of the hip dysplasia condition. But I think particularly these 2 papers in the last 10 years have shown us that we actually do alter the natural history, so that we collaborated with the Mayo guys and some other folks on both these papers. And the first one, the Charnley Award paper, really showed us that a ton of patients who have hip dysplasia, untreated, are going to develop osteoarthritis, and they develop osteoarthritis probably at a greater rate than patients with impingement do. And then the bigger question was, when we do a PAO, do we actually alter this natural history? And that second paper, I think, was one of the first to really prove that we can save a lot of these patients early total hip replacement with a well-done PAO. Here's another case. This is a 21-year-old female, pain for 2 years. She's a psychology student. You can see her physical exam, pretty flexible. And here's her, this is a little different situation. So we're focusing here on her left hip, and you can see her hip's thicker. I mean, she has a really diminutive acetabulum. You can see some irregularity in the sourceal. So we go ahead and get our advanced imaging, and she's actually surprisingly got a decent hyaline cartilage surface. She has a big labrum, which is a hypertrophic labrum, which is often the case in these patients with hip dysplasia. But at 21, we elected to do a PAO, and you can see this is a 12-month X-ray. I see her now all the time now. She's about 3 years out now. She has a really almost a perfect hip score. And so, again, I think the type of patient that can really benefit from providing enhanced stability to her hip and allowing pretty normal activity after that. So we don't worry about letting these people go back to running and jumping and competitive athletes. Dancers are common type of patient that we see. And, you know, with a total hip replacement, yeah, they probably can do those things, but we worry a little bit more about it. Now, this is one of the barriers to entry into the PAO world. The surgical technique is hard, and it's complex, and you got to spend a lot of time to learn it. So I learned, as I said early on, I spent a lot of time in cadavers with master surgeons, and then starting in my own patients with some mentoring along the way. This is a surgical technique video that's available from AOS. I'm not going to show you the whole thing, but the operation involves a series of orthogonal cuts in the ilium, the ischium, and the pubis. The key point is that this operation maintains the posterior column, so as you start to go around the back, I think you get a little hint that the posterior column is preserved, so we cut down through the quadrilateral plate. But keep the posterior column, and it allows us to free up the acetabulum and be able to move it, you know, with a great degree of range of motion within the surgical field. So if you're more interested, you can take a look at that video online. But the surgical technique is really critical. We're operating next to the, you can imagine the vasculature, the nerves that we are close to, femoral nerve, sciatic nerve. Getting osteotomes a little bit out of plane can be very sketchy, and so you have to get, I think, a ton of training to be safe and competent this operation. Here's another case I actually did just recently. This is a little more complex. So this is a hip that's not congruent. You can see that femoral head's really starting to subluxate. This is a 21-year-old female. Pretty affected. You can see her, in addition to the socket deformity, what's important here is her hip range of motion is 80 degrees internal rotation. So this is somebody who's manifesting increased femoral aneversion as well as acetabular dysplasia. So there's a small number of patients who actually need surgery or correct morphology correction on both sides of the joint, and this is one of those cases. So in these types of patients, this is a negative center edge angle, so you can really see quite severe acetabular dysplasia, undercoverage anterior on the false profile there on the right, and negative LCA on the left. Here's just a couple selections from her gun-site CT to look at her rotation. Now, most of the time when they have 80 degrees or 90 degrees of internal rotation, CT is going to quantify that at about 45, 50 of femoral aneversion. And if you do a PAO and you have somebody who has 45, 50 degrees of femoral aneversion, it's really hard to cover the femoral head adequately. So this is someone who needs surgery on both sides of the joint. So this is a derotation osteotomy done with kind of a mini open technique and a nail on the femur side, and then a really big correction on the acetabular side. You can see what's probably most important here are those two images on the right that show the improvement of her anterior coverage. So these are people who essentially walk on their hip capsule their whole life. It's so uncovered that they're barely walking with the head in the socket. And when you correct both sides of the joint here and they walk on with bone against bone for the first time, cartilage against cartilage for the first time, they see tremendous improvement. So that's her final post-op, and she's about 6 weeks out at this point and still recovering. But these types of people, these folks tend to do really well. This, if I am being honest, this is probably the most important slide in the whole presentation, and what I want to talk to you about is over the last 30 years for me, there's been this evolution in surgical technique, and a lot of times you're not cognizant of this as it's going on, but this is really what's happened. So when we first started, we did a big open procedure. We took down the rectus femoris. For almost a dozen years, we did a hip arthrotomy on every single patient. We improved head neck offset by using a bird. I kind of do a classic CAM improvement. We often did labral repairs. And in 2012, based on a lot of other experience happening across the world, I started doing it differently. I started doing a kind of a mini rectus sparing approach. The rectus left intact, didn't look in the joint, ignored the labral pathology, and lo and behold, patients did pretty well. Almost immediately, the physical therapist would go, "What did you do different?" Like the patient standing at the sink post-op day one, morning post-op day one, and walking around. And before we had to kind of help them. And so really noticeable improvement in early post-operative recovery by going to a less invasive soft tissue dissection. We made some anesthesia changes along the way. In 2018, we started using this Ortho grid digital measurement tool intraoperatively. And this was a huge, in my mind, it was kind of another light bulb moment. With PAO, we do this huge operation. The socket's free. You have kind of a couple joysticks, and then you're looking on fluoro, and you're going, looks pretty good. Put some screws in and call it good. It seemed kind of crazy to me that we didn't do a better job at quantifying exactly where we were putting the sockets. So we started using some digital tools in 2018. So over time, and then we started using nerve monitoring in 2020. I can tell you that story, but that was based on a nerve injury that I had. I have had one sciatic nerve injury. It's not a very nice complication to have in a young, active female patient. But if you look at this evolution, that's the trend. Less invasive, more accurate, and safer was what we felt like we were doing over the course of time. And I wanted to really kind of take a look and see if that was actually true. This is the Ortho grid system that we use intraoperatively. So some of you direct anterior, this is really big in direct anterior hips, but it's the fluoro basically is connected to this. It allows you to level the pelvis. It allows you to look at to correct distortion. And then it's basically a digital goniometer. So now for the first time, we could actually see exactly where we start and then exactly where we finish when we reposition the acetabular fragment. And in my mind, this was a huge advancement. After about a year or two of doing this, occasionally this thing wouldn't work. And if it didn't work, I felt like it's like the backup camera in your car, right? I mean, when it doesn't work, it's like, what the hell? Where am I going? So this has been, I think, a big advancement for us. So the digital tools, and this is the first generation. It's now refined where a lot of this is auto recognized, auto segmented right when you start the program. So it's really not a disruption in the surgical workflow. So this is actually 25-year data. So this is about 550 PAOs that I did. I now have one of my younger partners doing PAOs as well. We do about we've always done somewhere between 30 and 40 or so a year. Probably a little bit more recently. You can see the classic demographic things, but what we wanted to look at was in terms of how we corrected the acetabulum as we went through this period of transition. This is actually looking at the open surgery that we did with rectus takedown and arthrotomy versus the rectus sparing. And those numbers in red show we actually got better at putting in the socket in the target zone. So the target zones are shown up there in that little box on the right. We looked at how many people we got in that target zone. And lo and behold, as we went to a less invasive technique, we got better at positioning the socket. Now, some of this reflects an evolution in surgical experience as well. But nevertheless, we were encouraged that, okay, we're doing better surgeries, less invasive surgery, and we're not necessarily compromising our ability to put the socket in the right place. And then we looked at it with, when we add this fluoroscopic digital system to socket positioning, how do we do? And again, lo and behold, when we look at the parameters that we think are important for long-term outcome, we actually do better when we measure it intraoperatively with this digital tool. So we felt pretty good that the changes that we were making over time were worthwhile. Few words. So about big surgery, complications are going to happen, right? So these are the rates for us. It's a little higher than what we see with total hip replacement. So in 2% infection, 2% non-unions. Not all of those are a problem, but some of them are. Ischial stress fractures. That corner between the posterior column and the ischium gets really narrow, and some of these folks can develop a stress fracture early on. Those can be difficult to treat. And then in my mind, the biggest problem with this operation is nerve injury. So these are almost all young females, 85% female. And if you get a nerve injury, it's a very difficult thing to manage. So doing this operation safely has become my biggest focus. I'm kind of just ninja about retractor placement and training involvement. And so avoidance of nerve injury is really, really particularly key. So this, I'm going to talk a little bit about structural hip disease here too, and then impingement. But this whole area for me and my team has been tremendously intellectually stimulating. We've published a ton of papers now on a number of things regarding PAO and impingement surgery and morphology in young adult patients. It's been really academically gratifying. I don't do this work just to get more papers. I find it super intellectually stimulating. We published this paper. So this is on the bottom here. This video is an open surgical dislocation in a patient with a pretty severe cam lesion. You can watch it as I'm talking, but you'll be able to see this kind of dynamic femoroacetabular impingement between the rim. So this paper was published in 2006. It was about 2002 or 3, and I was standing. Josh Jacobs he's the chairman, longtime chairman at Rush, one of my mentors at Rush. I was standing in line at a hip society meeting with him, and I said, "Josh, we're dislocating some hips in young people." And he looked at me and he's like, "What? That sounds nuts." But But if you're going to do it, at least put some science to it. And Josh has always been a great mentor to me. And so it really kind of stimulates. That's the cartilage injury that you see often, that delamination injury. It's really, really consistent pattern with impingement of the hip. Not a lot of great ways to manage that. We still do the same thing, microfracture, glue behind it. But anyway, Josh said, put some science to it. I went home. I was doing some FEA work with a couple other PhDs related to joint replacement. And I said, hey guys, what could we do to look at this idea of structural hip disease? And I started talking to people nationally about structural hip disease research. And oh man, that's the best video of the whole thing. I gotta show you that. This is my little kid. I hate Costco. This is in Costco. And this is how I felt. I took this video because I was like, that's how I felt. I was like, right there. Like, I want to put my head in the sand. I don't want to go talk about this stuff nationally. But we came up with kind of a concept to look at structural hip disease in a translational basic research fashion. And so we developed some FEA models we recruited normal patients first, some of our lab people, friends, family. We would do a CTA arthrogram. We would create these three-dimensional models and then an FEA model. And we really wanted to get to the point where we didn't have to use cadavers and things like that to look at this stuff. And we validated that against traditional cadaver models with Fujifilm and things like that. And we started to be able to develop these three-dimensional models where we could actually move the hip in space. We could see a contact stress distribution across the acetabulum, which was really cool. For the first time, we could see this in 3D. But the important part here is that this is kinematic data that is gleaned from the literature that is driving the femur within the acetabulum. So it's making it up. It's putting the hip through a range of motion. And what's interesting is a lot of hip replacement planning programs today from certain companies move the hip around in space just like this. And they then predict collision modeling and predict component placement from collision modeling. And it's hocus pocus. It's moving bones in space. And we really wanted to be able to get to a point where we could see what is actually happening to a particular patient in vivo when you remove the hip. In other words, get at subject-specific hip kinematics. That's what we really wanted to get to. But early on, we did this in normal patients. We saw stresses were variable, even in normal hips. We started modeling dysplastic hips, and we saw, lo and behold, that the stresses are not normal. So these red spots are areas of high stress concentration. And, for the first time, we kind of said, okay, actually, structural hip disease is a real thing. It alters stress distribution across the hyoid cartilage. Low to the labrum here, shown on the top in green, is much greater in dysplastic hips than it is in normal hips. And the quantitative results supported our clinical observations that this is an outside-in OA progression. So the labrum gets injured, and then the OA progression starts from the labrum inward. So we thought we were in the right place. We wanted to still get at this in vivo hip articulation and kinematic. The kinematic thing was really what we wanted to get at. And so we developed a lab. This is some of our NIH work where we have an instrumented treadmill. We have dual fluoroscopy systems. We can actually do patient exams under dual fluoroscopy. We can get these types of models. So this is a 3D model generated. Now we're actually moving the patient's hip using the dual fluoroscopy to show us exactly how the hip's moving in space. You can see the contact there in red between the labrum and the femoral head. And that, for the first time, kind of showed us that, okay, we can actually see what is actually happening in the hip in real time. This is an example of one of our normal control patients walking, and so that image on the right is a 3D image generated from CT, and then that's the actual kinematics of what's happening to the pelvis and the hip joint. So we do this now and a number of other modalities. We use statistical shape modeling to look at differences in patient populations. So this is looking at Japanese patients and American patients with hip dysplasia. We see subtle differences throughout the entire innominate bone. So we use a lot of these tools to look at structural hip disease. And this is kind of the conclusion slide on structural hip disease. I put this together just to kind of show we know we can recognize that hip on the left is abnormal. I think we still don't understand a ton of what's happening with structural hip disease, and hopefully some of these tools can help us in the future. We continue to recruit patients and controls. We have a library now of about 200 patients with full imaging and kinematic data, and continue to work on this stuff with our lab partners. Just talk about a couple words, a few minutes about mastery. So I've been fortunate to train with some of the giants in orthopedics. I talked about Gons and Mast. That's George Galante on the right, Aaron Rosenberg from Rush. Aaron Rosenberg just passed away. My Utah mentors on the bottom left. And I've learned a lot about the value of trying to achieve mastery in surgery. I think surgical skill gets undervalued in our world today. This is a book I'd really recommend to you, especially for some of the younger guys who are training. George Leonard. I'll let you read those things, those two paragraphs above and below. But what I think the key point here is that we, especially in America, we focus on these things. Get better, fellowship, residency. I went to a course, I got better. And we don't focus very much on the plateau. And Leonard's point is really what mastery is about is really enjoying your time on the plateau, really enjoying the time where you're just cranking it out case after case after case. And that's really how we achieve mastery, is getting to that. It's that repetition. It's that really getting to a point of being kind of unconscious doing what we do. And that's when you watch master surgeons, that's where they are. They benefited from being on the plateau for a long, long time. So he says to love the plateau is to love what is most essential and enduring in your life. And I think the more I do the PAO operation, I think about this a lot. And it's really counter to our culture, if you think about it. I mean, all of our phones, all of TikTok, social media, everything is about get better, jump up. And there's not much emphasis on enjoying the time of the plateau. So when you're cranking away doing your 25th, IM nail for a tibia fracture, know that you're probably on the plateau there, and it should be an enjoyable time. Here's some more AA slides that just kind of emphasize the same concept. But take home messages: love the plateau. The journey of mastery is, I think, the ultimate human activity. And if you want one book that kind of emphasizes this concept, Aaron Rosenberg used to give this book to our fellows. It's called Shop Class of Soulcraft. It's about a guy who's a Wall Street master, cranking it on Wall Street, making a ton of money. His passion's really repairing vintage motorcycles. So he does Wall Street for about 10 years, and he says, screw this, goes back to fixing motorcycles, and ends up having, the biggest classic motorcycle repair practice in the country. And he talks a ton about, how much fulfillment that brought him compared to his little chaotic life of not being on the plateau at Wall Street. So this is, in my mind, the important stuff. These are the conclusions. That's my little girl a long time ago. These are the things that I value the most. Lucky to work with a ton of personnel, both in the lab and in the clinic. I'm going to talk a little bit about our clinic folks in the next talk, and acknowledge the funding and affiliate labs. And thank you very much for your attention.
Okay, some time for questions. Any other questions?
I have questions.
Sure.
Questions?
Hip arthroscopist, I've been here for 13 years. I've actually brought here to try to help build up hip preservation practice here. And admittedly, I think our understanding of instability and hip dysplasia, I think, was limited early on in developing that. As we speak, actually, that could need the trauma partner of ours who started getting into the PA. I think understanding kind of what role it plays in young hip disease. I guess my question is, where does arthroscopy fit in your practice? Is there, you show these hypertrophic labrums, you show these cartilage disease, like, is there a place for arthroscopy in your business?
Yeah. So I understand. I didn't know that Aoki was here last year. That's That's great. I mean, I love Steve Aoki, and we have a great thing. We have kind of for many years, we have, really tried to develop a comprehensive hip preservation system. Patients can come in and see either one of us, and we have another guy who does hip arthroscopy as well. Occasionally, we do a kind of multidisciplinary conference a couple times a year where we talk about, who should be seeing who. We kind of know that by now, but the bottom line is, I think you need both. You need to offer both. I mean, I think clearly people with impingement, young people with impingement, they're better treated with hip arthroscopy most of the time. I mean, the indications for open surgical hip dislocation now are so small. It's sequelae of pediatric hip disease, bad Perthes, bad Skiffy. Straightforward impingement. Straightforward dysplasia, obviously, I think should be treated with PAO. Now, there's a whole bunch of people in the middle, as you know. And so what do you do with those? And so what we just take it case by case. Sometimes a patient ends up in my clinic, and I think they're better for Steve's. And I walk them over. We do clinic on the same day. I walk them over and go, hey, can you see this guy? Yeah, no problem. And he does the same thing to me. So I think you need a partnership. There are a few people in North America who have the whole package. They can do scopes, PAO, total hip. Not very common. I think those generally are different. Open surgery, hip arthroscopy, different skill sets. I think it's very hard to do both well. And but I think the take-home message is you need a collaboration of people who can offer kind of both operations.
Do you ever do them combined? Do you ever?
Rarely. So rarely, as you know. I mean, they're probably the shortest answer to you is Paul Belay from Canada, has in press an anchor-based study looking at scope, no scope at the time of PAO, and what it shows is no difference at 2 years, RCT. And I think there was a time where their gravitational pull was, hey, it makes sense to do scope at the time of PAO. A lot of reasons not to do it. Field's harder, bunch of fluid, already a dangerous operation. Most PAO surgeons don't want anything else to kind of make that harder. We did a few early on. I didn't love it. We've actually looked at our rate of subsequent hip arthroscopy by not looking in the joint. At 5 years, it's about 8-9%. So I tell patients 1 in 10 are going to need a subsequent scope. To me, in a controlled environment, that's a better way to go than trying to do it on every case at the time. Plus, it's adds OR time. That becomes, for me, a PAO is an hour and a half operation maybe, and you add a scope to that. Now you're talking 3-4 hours. I don't think it's a good idea. So I think staging them is a better way to go. There are some patients who we will stage before big cam and dysplasia. Maybe treat the cam first and then do the PAO later. So those are kind of the subtleties.
Thank you for that one. Kind of related to that is what is your approach to the patients with borderline hip dysplasia? Data will suggest that they could benefit from just isolated hip arthroscopy, isolated PAO. What's your approach to those patients, and are there any patient or radiographic images that help sway you?
Yeah. So that's the mystery population, the border. So-called borderline. We don't really know what borderline means, but yeah, it's a patient with, let's say, LCA 20. My hip hurts. A lot of times it hurts with yoga and during my 26-mile run on the weekend, and those are hard patients. There's no easy way. There are imaging findings that can lead you one way or the other. There's exam findings trying to really get at, is this more of an instability picture or an impingement picture? Some of these people can have impingement because they have supraphysiologic range of motion. I don't know that we're very good at fixing those people. The literature, I would argue, is my interpretation of literature is contrary to what you just said. That yes, there are some positive results of hip arthroscopy, but there are some shitty results. And those shitty results stay in the paper. They say these results are good, and 35% of the people had subsequent surgery weren't doing well. So you have to be a little careful. The literature on PAO for borderline borderline dysplasia is bomber good. It's really good, like 100% survival. And so I think we should be erring more towards PAO in those patients, but others would look at it differently.
Looking into the future with the crystal ball,
Yeah.
would you predict that the term structural hip disease is going to become refined into a much more precise description of diseases and disorders in the same manner that internal derangement of the knee
Yeah.
used to describe everything that's going on in here?
Absolutely. I think it already is. I use that term kind of in a broad audience of, non-hip specific people to just try and, because it makes some sense that we're dealing with a morphology problem. But we already see that happening. And I mean, what you're getting at is we need a better lexicon of the terms that we're talking about. In our world, you hear all kinds of things: borderline, micro instability, all these things that really don't have a true definition. There's actually a paper that's going to come out in JGS in the next 3 or 4 months on the lexicon of structural hip disease. That is exactly to your point. And so, yeah, I think we will get even better with that.
Dr. Talk.
Thank you.
Talk about the outcomes of having to convert people that have progressed to osteoarthritis post osteo.
Yeah, that's a good question. Yeah.
Clearly with, dysplasia, that's a more complex operation for total hip, given patient population, age, and underappreciating the three-dimensional morphology. But can you talk about when these people do come to total hip, how they turn out?
Yeah, and I'm seeing a lot. I have 20+ year follow-ups coming in now, and I'm converting probably more than I ever have at this point in time. And we actually were interested in that. We looked at it with a multi-center group because nobody has a ton. But I think
That's a good thing.
yeah, exactly. Yeah, the multi-center group. I think we ended up putting 40 or so patients together and tried to age sex matching to a control group of OA, and actually the functional outcomes are pretty similar. As you'd expect in any prior operating group, the kind of perioperative complications are a little higher wound problems. There wasn't a difference in dislocation rate. So, but it's an N of 40, it's like anything in a prior operating field. You just have to be really careful. And I think if the PAO's been done well, it's pretty much a straightforward primary operation. The hard ones, like I can show you some x-rays where PAO's overcorrected, not, 40 degrees retroverted. Now those are different stories. Yeah.
In the last decade, we've spent a lot of time talking about cup position and total hip arthroplasty, right? What's the target?
Yeah.
Is there any discussion in the PAO world about the target? Like, what are you aiming for? Does it depend on functional pelvic position? Is it all static? Is it all 2D? Is there some spinal pelvic discussion going on? How do you know where to put that socket? Has that changed?
Yeah, it's interesting because it is being talked about. The difference is most these people usually have flexible spines. It's really not. It's really rare to see somebody with a stiff spine and hip concomitant hip dysplasia. So, what we try and do is replicate what, from an imaging standpoint, standing AP pelvis, and then intraoperatively trying to imitate that position of the pelvis on fluoro. But the actual positioning of the socket is still pretty much static measurements. It's like you're trying to get. We don't pay as much attention to true quantitative abduction and version, but what we pay attention to is LCA, which is kind of like abduction, and then posterior anterior wall ratios, trying to get the posterior wall center of the femoral head. So it's a much more kind of gestalt view, not using finite numbers to quantify.
It's interesting too. It's all 2D, right? Obviously, it's a very complex 3D
Yeah.
situation with some of the tech we're seeing now. You wonder if maybe that's next. If
People are starting to play.
Yeah.
Put an array on the fragment while you're doing it, and we're starting to see people play with that. Yeah.
All right. Good to
Keep on going?
Yeah, keep on going.
Okay.
Put you to work here.
Wow, I said that's as much as I talk in a day, so. Okay, so, I talked to JB, I was like, what do you guys want? A clinical talk and then some touchy-feely talk. I don't know. I don't love the touchy-feely talks, like you don't care what I value, but I was talking to our fellows and they go, you know what, this was a couple months ago, they go, when we're in your OR, it's like it's the calmest environment, your people you work with all love you, and you should put a talk together on how you do that. And I was like, oh God, I don't know how I do that. I just do it. And I mean, so that concept led to like, okay, how we put together a good group of adult reconstruction surgeons over the last 30 years. And I think a lot of the same concepts are in this talk, kind of focusing on the division as well as kind of those interactions on a day-to-day basis in the OR. So hopefully you'll get a feel for it. A lot of this is a mix of leadership stuff, business stuff, and then some touchy-feely stuff. So here you go. This is 1990. I joined the faculty in Utah in 94. That's a picture from our faculty in 97, and then 2024 here. This is not our whole faculty, but a recent graduation ceremony. We have about 60 faculty total. When I joined the faculty in 94, I was I think, 9th guy in our program. You can see me there in the back on the right, super skinny. I hate that picture, but yeah. And I had one other partner at that time doing joint replacement, Aaron Hoffman, who's kind of a giant in the field of particularly knee replacement surgery. He developed a whole knee system called the natural knee. He was, I don't know, probably 15, 16 years older than me. I came on headstrong, aggressive. He trained me, thought things would be hunky-dory. Within 2 years, he was like, you need to go. You need to get out of here. This isn't working for me. And I went to my chair and I was like, what the hell do I do? And he basically said, just put your head down, go to work, publish your papers, everything will turn out fine. So this was me back in 94. One of the things you'll learn from if there are some old people in the room, is no matter how you look, your brain feels like those pictures, that feels the same as on the right, hopefully with a little bit more wisdom. And I would highly recommend this book. It's called has anybody read this book, From Strength, heard of it? Strength to Strength? Especially if it's a great book. It's a great book, right? So
your second act, I've been trying to figure that out for the last few years.
Your second act, it talks about two curves. This is the curve that we function on for most of our really effective life. And then as you get older, your doing skills go downhill. But fortunately, in most people, you can use your wisdom, your accumulated experience to kind of do great things in the second act of your life. He talks about fluid intelligence, crystalline intelligence, but basically it's a concept that allows us to use some of the accumulated wisdom and experience later in life. And I tried to do some of that with this book. I have very few things that I think are important and that I've tried to instill in our faculty and the way I built it. The first thing is be aspirational. Everyone saw Artemis last couple of weeks. To me, this, Apollo 1969, we walked on the moon with a computer technology that is less than what all of us have in our pocket today, which is really, to me, this is the most astounding thing I've ever experienced and seen in my life. And so I just think being aspirational as a leader or putting something together, putting a group together is the absolute number one key. We talked a little bit about this last night. The second thing I think is important is culture trumps strategy. So getting the right people, the right culture together is really, I think, priority number 2 in my mind. When you get the right people and you get the right culture, this other stuff, teamwork, respect, integrity, innovation, all of that stuff kind of comes together fairly naturally. And this I didn't realize I use this picture a lot in some of my talks that I forgot that I was like going to be in James Madison backyard. But so all of you know this guy, and I think to me it's one of the best stories in sports that I've ever seen. Like the influence of one man changing the culture, I think is both at James Madison and at Indiana. I think is to me it's really powerful that you can actually influence the organization that you're in. This is another quote from. This is kind of how you get to the cultural part. So this book is a famous business book, Good to Great. If we get the right people on the bus, the right people in the right seats, that's really important. Wrong people off the bus, and then we'll figure out where to go from there. So this is something that I think I did. I really wasn't conscious of it while I was building the division that I work in now, but it's absolutely how we've built our place into a really highly effective adult recon division. Hopefully some of these concepts, whether you're in joint placement or not, you can, if you're a hand group or a foot group, you can take some of this stuff and make a difference. So great vision without great people is irrelevant. So it's all about people. Bobby and I had the same conversation last night. It's when you get the right people on the bus, good things happen. And then the third thing, so I was big on aspiration, get the culture right, and then empower the people that you bring onto the team. Give them what they need. Here's another AI slide. So when you don't have empowerment, you start with central decisions, limited ownership. People are just kind of walking around in zombie land. And when you empower them, you give them ownership, decision authority, you check on how they're doing, you give them access to data, which gets them invested. So to me, it's the three things I've emphasized in our group is when we hire new people, when we think about change, be aspirational, get the culture right, and then empower the people that not only that we work with, but the people that we hire. So this is our group. Jana, we have this, I want to talk about Jana because she is the key. She is the glue that holds us together. Those are my 5 partners. These are the team members that we have. We have 6 PAs, 4 nurses, schedulers, medical assistants, really similar to you guys. I think we have 4 great PTs who work with us in clinic every day. We're in clinic. They see our patients post-op. They run our outpatient joint replacement program. They touch every single patient. The power of PTs for us in our practice has been tremendous. A lot of our patients think these people are, more instrumental in their overall care than we are as surgeons. So we've hired every single person with kind of a different spin on or a different strength in either their personality or their practice style or their expertise. So you've heard about what I do. This is Jeremy Gilland. He's just became our service chief in the last 6 months or so. He started out as our research director. He's incredibly skilled at researching, DA expert, complex arthroplasty. He was one of the surgeons who helped develop that Ortho grid system I talked to you about. This is Chris Pelt. You can see all these people are in the Hip and Knee Society. I'm going to talk to you a little bit about that. He's the chief value officer. He is the process guy. He knows, CMS, payments, systems, process-related things like the back of his hand. He's the guy who we send to interface with our hospital administrators because they speak Chinese. And so it's really, I think, critical in the clinical realm to have somebody who can communicate. Lucas Anderson, we designated as our education chief, so he handles everything education-related, fellowship, residence, core curriculum, is actually out there every single day trying to be better at making our educational offerings better. He's going to follow in my footsteps in the hip preservation world. And then Mike Archibek he came to us about 4 or 5 years ago as a mid-career guy. He was trained with us early on as a resident. Been trying to get him back to Utah for 20 years. Finally, he raised his kids in New Mexico and said, "Hey, I think I want to come back." If anybody holds our culture, the glue to our culture together, it's him. He's just an amazing human being, and think it's super important when you have, as your group starts to get bigger, to have somebody who kind of has an incredibly well-balanced outlook on life, makes the group super powerful. And then we're going to hire our sixth surgeon, Josh Rainey, he's in Mayo right now doing fellowship, and he'll start in September. He's already, he comes with 50 publications as a fellow. He's the #1 reviewer for Journal of Arthroplasty. Guy's a superstar. And so I think when you get these other things right, these are the kind of people that you can attract. So we track our productivity. I'm going to get to Jana here in a minute, but we track our productivity from an academic standpoint. To me, it's always been important to not only knock it out of the park clinically, but to knock it out of the park academically as well. And I get asked a lot why the emphasis on the academic side. And here's another AI slide. Everybody seen Hamilton? Yeah. So I love that scene in the room where it happens. And to me, when I think about why you want to be involved academically, particularly in our field, to me, those things are like the Hip and Knee Society, AUKUS, International Hip Society, places where you exchange ideas, you meet new people, you get your level of thinking challenged. And to me, there's no better way to keep up on the state of our field and to get new ideas than to be in the room where it happens. So we saw those little Knee and Hip Society bullets on each picture. We encourage all of our people to strive for inclusion in the Knee Society, in the Hip Society. We try and get as many of our folks to attend CCJR, the flagship meeting for the Hip and Knee Society in Florida in December. We really heavily participate in traveling fellowship programs. This is the Insult Traveling Fellowship. This is the Rothman Traveling Fellowship, Rothman-Ranawat. So these are another opportunity to exchange ideas. These folks come, international and North American participants. They spend 3 to 5 days at your place. Great exchange of ideas, socialization, meet people with different perspectives, different experiences. And we do both these fellowships every year for the last, 7, 8 years. One of the best things that we do from a faculty standpoint. That's a lot, but all of our guys are incredibly well-balanced people. They all have families. Interestingly, 5 of the 6 of us have girls. 1 of the 6 of us has boys, but everybody's an incredible family, dedicated member, and then everybody has a really strong recreational focus as well. So one of the things that I think we've learned is that the people who thrive in our program are people who have that work hard, play hard mentality, and that's, I think, served us well in adding faculty over time. We spend a tremendous amount of time focusing on our fellowship. This is just a little collage of the fellows over the years. Have over 20-year experience now. We take 3 fellows. This is the best part of education for, I think, almost all of us. We have a really strong core curriculum of topics that we cover every year. We socialize the heck out of it with these guys. They're in the OR, cranking it out. Today, most of these folks are doing 800 plus cases with us in their year. And it's really the best thing that we do. Just some more examples of recreation. I think it just reinforces it's about the people. This is Jana. So she's our service coordinator. I said, I need a slide that, Jana, you got to make a slide that tells me everything you do. And so she's like, here's my spider web. And it seems ridiculous, but this is what she does. She runs the whole show. And I'll just tell you a story about her. So there's a bottle of wine there on the left. She started as a surgery scheduler for us. She got burned out like they all do. And she came to me and said, I'm quitting. I said, oh God, I hate to lose you. I gave her that bottle of wine. And I said, we will, if you want to stay, we'll create another position for you where you run the whole show. And she came back a week later and she's like, gives me the bottle of wine back. Says, yeah, I want to do that. So that was about 8 years ago. She does everything for us. Plane tickets for 6 guys. 5 guys, 6 guys. She does plane tickets, travel, all the fellows travel, everything, weekly schedule. This is the type of thing. And to me, to run a service without someone like this person is impossible. We're very fortunate as well to work with a really great clinical research group. This is kind of the mission and core philosophy of our research group. We have a core study team, usually consists of 3 people. The key person is Brenda Blackburn. She's up there. She's a PhD. And she started with us over 10 years ago, 8 years ago. And she runs the show. We usually have these 2 full-time assistants. We leverage medical students, both as volunteers, some paid summer students. We have our fellows doing some research as well. We really try and get residents involved, but that's a little bit tougher. We have multi-center studies going with other institutions. We try and get involved in national organizations as well. Funding is always the problem with research in an academic setting. So we try and fund our studies as much as possible, but we really rely on industry a lot. So we always have some industry studies going on, really trying to bring in money that allows us to fund some of our investigator initiative studies. And that's been a helpful model to kind of keep our research team together. We track our research output. You can see these are just our podiums, posters, manuscripts in gray. Each year we have a meeting pretty much every month with our research team and the whole faculty, and we just kind of go through what's going on and what we need to be looking out for the future. I've talked to you about the relationship with that translational research team, that's ongoing as well. This is the other key person in our department. This is Jill Erickson. She started as a PA. We've worked together for 26 years together. She's been my PA for 26 years, which is crazy. You don't see that very much anymore. But later in her career, she's morphed into this quality and electronic health record specialist. And so she does all of this stuff for us now. She's an Epic specialist. She does quality dashboards. These are the type of things we get. This is a Tableau report. I don't know, do you guys have Tableau? Do you guys use that? Yeah, so this was just our experience during, this was the outpatient epiphany. COVID happens here. We were outpatient 15%, and then all of a sudden, the gray bars, all of a sudden our joint replacement went to 85% outpatient. And the hospital loved us for about a month. And then they said, that's great. You guys, you kept us alive. Now can you get out? Can you go find somewhere else to operate? But it's another story. So we get these graphs now, and everybody gets it. So these are published and accessible to all the faculty. We can look at our total joints, total amount of joint replacements, primary revisions. We look at the overall cases for the last 12 months. We can go back somewhere around 4 to 5 years and kind of see how our rate of growth is. We get these monthly activity reports. This one's just looking at RVU growth. So every single person at our joint replacement meetings gets access to this data. We can look at contribution margin. So we know our primary joints have a 35% contribution margin. That's down, back in the day when we admitted people, that was higher than 40%. So part of the reason why we lose clout a little bit is our contribution margin's gone down. Jill now leads this effort for the entire department, so we get quality data. This is just reoperation rates for the entire department now, and then we get an infection dashboard. So you get the idea. We can track our day surgery patients. So for us, overall, our primaries go home 71% of the time. If you're a candidate for outpatient surgery, we get you home 94% of the time with day surgery, and average length of stay for us on day surgery now is about 5 to 6 hours. So anyway, you get the point. We use this patient engagement. Do you guys use a patient engagement platform?
Yes.
So this is a chatbot system called Streamed. It's one of the best things we've done. It's a two-way communication system with the patient. You get evidence-based content, pre-op, post-op. It's all text-based. Patient signs up. They get all this information posted to their phone. You get the right, so the patient gets the right information at the right time. Covers all these things: infection prevention, mental health, opioid safety. They can reply. So I'm in a ton of pain. What should you do? They get a response back. And I can't tell you virtually every single patient that comes in and goes, I love your text. I love your text. And I mean, some of them realize it's a robot, but a lot of them don't. A lot of them think we're texting them every day. And they're like, oh yeah, my hip's good. My hip's good. Your text. I mean, literally, that's how it goes in clinic every single day. It's one of the best things we've done. Instructional therapy videos, the patient gets those. So a lot of times now, people are not going to formal physical therapy. RPTs use this system to communicate directly with the patients. Saves us a ton of time. So just some thoughts on outpatient joint replacement. I mean, this team that's really led by Jill has been amazing. Again, having someone as the point person who's passionate about it really gets everybody on board. And we've seen a tremendous reduction in phone calls and reduction in staff burden. So this, I think, is the final slide. I mean, this is how I think about things now. I mean, early in my career, the focus was on me, get successful status, getting stuff. And really, to me, I've seen the shift to being over here and making the team the focus, making the success of the team, making the success of your partners really the goal. And I can't tell you how fulfilling that has been to watch these guys thrive and grow. And it's been a tremendous honor to be involved with all these folks. I'll leave you with this last slide. Is it easy? No. This is, in my mind, this is part of the problem. Growth of hospital administrators, growth of surgeons. And it's a battle for us every day. And then maybe it's easier for you guys. I don't know, but it's about you have to be persistent and you have to kind of really continue to fight for yourselves because what we do has tremendous value for patients. Everybody knows about this book on the right. I read it. My wife got so tired of me telling her to let them, and so she said I can't talk about it anymore. But I don't know. Is that the right thing to do? Let them continue to mess with us? I'm not sure. I'm not sure it's the right approach. I don't have the answers, but I'll leave you with that to contemplate for the rest of the morning. Thanks for your attention.
Ask a question on that talk too.
Yeah.
So as a residency program director, I mean, I've tried to build curriculum for instance, and some of our residents like Charlie's going in arthroplasty, but I think it's so important for residents to learn arthroplasty. How do you integrate your residents onto your arthroplasty team? Like, at what levels do you have them on your service, and how do you inspire them to go into arthroplasty?
Yeah, I don't know that we do the best. I mean, I think we're a lot like you guys. We get one, sometimes two a year. So we get them as ones. I'm not really sure it's a very good idea, but ones, 3 and 5s. And so we usually have 4 residents on the service. And everybody's pretty much the same, graduated responsibilities, one-on-one usually they're with each of us for about 2 weeks. The fellows are fantastic at helping them integrate into our team. We have an incredible dedicated what we call ski lab, which is a cadaver-based lab in the basement of our building. And one of the commitments from the department has been you can go down there, you can get a cadaver, you can go do a total knee anytime you want. And so we end up organizing a lot of labs pretty much at the beginning of each rotation. We'll bring in one knee system, one hip system. One of us will go down there and kind of put on a cadaver-based thing so that at least they've got some tools in their hands before they get to us. That's kind of it. That's been trying to integrate them. And then, that whether we get them to be interested for life, that's a more complicated discussion.
I guess my question also is because I think arthroplasty can be a part of their practice if they go into private practice. Like how do you get a resident trained to do arthroplasty at a basic level after they graduate? Those who do not go into residence to a fellowship. Yeah, I think I feel pretty comfortable that most of our graduating residents are pretty competent at primary joint replacement by the time they leave. Maybe DA hips you might need a little more time, although they see a ton of DA hips at our place. But I think most of them can be very competent going into practice.
with doing pretty straightforward primary drugs. Did you feel, I mean, would you have felt that way? Yeah, yeah.
So Chris, thank you very much for both talks. I'm just curious, we're probably doing 70% what they are, maybe less. About in terms of the organization of the division. You say that higher or lower?
What do you mean, 70% what?
Of what he just presented in terms of the organization of the divisions.
Size
The
of the division?
resources and so forth. And,
Yeah, we're not.
but the patient engagement, all that stuff that we're missing. So, yeah, we have some of this, we're moving toward more, but we do have some struggles because we don't have the support, as we talked about, of the medical center sometimes.
Yeah.
In the health system. What in relation to your other divisions in orthopedics,
Yeah.
are you much more advanced than they are, or are others following your model, and are they similar to you? I know every division's a little different, but
Yeah. We have a spectrum. We definitely are, I would say, the most productive and organized and evolved. But we have several others, like our spine group is very close to what we do in terms of resources, in terms of patient care related things. Our sports group is a bit more fragmented, providers in different places, a little bit more difficult. We have a growing now 3-member shoulder and elbow team who's very much following our model and really knocking it out of the park. And we have other divisions like and pediatrics that are chaotic. And, you know, from a department standpoint, what we try to do is just show people, here's a model that has proven to be successful. Take from it what you will, and you hope that those folks will run with it. But we stay pretty decentralized and let those folks try and do it on their own. Some are successful, some aren't.
I'm impressed by the organization, obviously, but also something that we talked about last night is the culture. You have to have the right people to get results like this, but you also need transparency. And, I'm someone who's very transparent about, volumes, finances, everything. I've been from day one, and I get criticized by other chairs, but the level of transparency you have is outstanding. And I think that, helps with developing a culture.
I do too, and I think, and I believe me, I get pushback all the time especially from the hospital side or the medical center side. Like don't show that contribution margin number. I'm like, screw you. I mean, it's public. I mean, it's accessible, and we're better if we know the data. And so I think you're right. I mean, I feel really strongly that people they feel more involved, more empowered when they know exactly what's going on.
More questions? Well,
Thank you all very much. Yeah.
just a few gifts from UVA Ortho. So since we don't ever play you, so you can walk.
Yeah. Very good.
And some shirts and most importantly, the plaque for the town ground visiting for about the year. So thank you for coming all this way, and I've really enjoyed getting to meet you, getting to know you, and we appreciate your education.
Yeah, thanks very much.
Thanks.
Yeah, thank you. Good.
Everybody stay just for 3 minutes afterwards. For a special announcement, Nabil. So we have a very special announcement from the Mulholland Society, which is a group of medical student organization who help recognize excellence in our residents. And so Nabil is here for a quick presentation, so thanks for being here.
Good morning, everyone. My name is Nabil Raza, and I am the class president of the class of 2027. I'm presenting the Mulholland Resident and Fellow Teaching Award on behalf of the Mulholland Society, which is the student government at the University of Virginia Medical School. It's an honor to stand before you today to recognize an individual who represents the very best of our community. This year, we've received nominations for more than 20 outstanding residents, each one demonstrating dedication, compassion, and excellence in their work. Being nominated alone is a significant achievement, reflecting the respect and admiration of peers and mentors alike. To be selected from such a competitive and accomplished group speaks volumes about the impact this resident has made, not only in her clinical work, but in the lives of patients, colleagues, and the broader community. The resident receiving this award today was described by her Associate Program Director, medical students, and fellows as an outstanding mentor who not only teaches technical and clinical skills, but also instills confidence and a sense of belonging in a demanding specialty. She is consistently described as approachable, highly organized, and deeply invested in student success, creating an environment in which students feel valued, empowered, and motivated to excel. This combination of approachability and high standards is the hallmark of a truly exceptional resident. One nomination detailed their experience with this resident when this resident was here at UVA. The nomination writes, "I knew her as my advisee as a UVA medical student. I could tell that she had qualities that differentiated her from her classmates. She embodies a rare combination of clinical excellence, intellectual rigor, and an instinctive commitment to teaching. Faculty evaluations consistently describe her as the most prepared resident, completely trustworthy, and operating above the expected level for her training, with advanced technical skills, outstanding communication, and exceptional ownership of patient care. Her teaching is not passive or incidental. It is intentional, structured, and learner-centered. On service, she reliably assumes responsibility for orienting and integrating medical students into the clinical environment, creating a psychologically safe and academically rigorous space in which students can thrive. She is equally effective in the operating room, clinic, and on the floor, where she provides real-time instruction, anticipatory guidance, and clear expectations that elevate student performance. As noted by her colleagues, she goes above and beyond to welcome nervous and inexperienced students, ensuring that each learner feels supported while being challenged to improve. The winner of the Mulholland Resident and Fellow Teaching Award is Maddie Shroof."
Thank you so much for coming, Bill. And this is why we do what we do. So Maddie, you're outstanding. We really appreciate you for all you do. So thanks. Thanks all for saying.
Now you got me wearing my UVA jacket. You want me to take a picture of you guys?
Yeah. Hey, guys, we gotta go ahead. Hey, guys, take some burritos for lunch, please.
So well.
Yeah, it actually was done by like.
Yeah, no. Sorry.